I have the great pleasure now of introducing Dr. Angela Massey-Hill, who is an alumnus of this conference. She had been an instructor at Florida A&M in their College of Pharmacy and Pharmaceutical Sciences for several years, and then we in the community were all very sad when she left us in the Memory Disorders Clinic and went down to Tampa to join the Bird Center at University of South Florida. She is now professor and chair of the Department of Pharmacotherapeutics and Clinical Research and associate dean of clinical practice. So she's having a tremendous influence on the community, recruiting and training additional practitioners there. She is also the pharmacy consultant at the USF Alzheimer's Bird Center Institute, where she is involved in comprehensive medication reviews and patient visits, helps with drug-related research, outreach. So she is not only keeping her hand in the academic world, but also doing direct outreach and service in our patient care world. While she is there, she does work closely with their memory care center and collaborates with the clinicians there on scientific research, as well as speaking to groups of medical professionals, students, and caregivers like us. So she is very passionate about helping patients and caregivers understand and manage their medications and speaks at support groups quite frequently. So before she left us, she had obtained her Doctor of Pharmacy degree from Florida A&M, and so we are actually proud to claim her as being one of our Tallahassee native trainers and being home for us. So welcome back, Dr. Massey. Are you going to use the... Okay. Good morning.
About now? Okay, great. Thank you. Thank you for that welcome home. And it truly, truly, truly is a pleasure to be back at the conference and certainly to be able to see all of you. Some of you we're meeting for the first time, and some of you I've been seeing for years, and I've missed you sincerely. So this is a pleasure this morning to come back and talk to you and certainly be highlighted as the keynote speaker. It's like, wow, that's really, really, really impressive. So today we're going to talk a little bit about herbals. Because there's so much out there, and over the span of my career, you know, I left here very passionate about ginkgo, and life has just opened up in this arena. So I think as we talk about where we are going in terms of treatment opportunities and those kind of things, I really like for everyone to walk away understanding that the herbals may in fact play more of a role than they have in the past, but I want you to understand how, where, and what they're actually doing. But we have to do it in the backdrop of some of the things I'm going to talk about and Dr. Pomodoro is going to talk about later in terms of research. Because when we answer the question about is this our future, through the talk, I want you to understand that with anything there are going to be limitations in that regard. So I like to always start off with some things that you all are seeing, and I was curious if any of you had seen. I want to tell you a story.
Your brain needs proper nutrition every day because life can be a bit overwhelming. Focus Factor is America's #1 brain health supplement. It nourishes your brain with vitamins, minerals, antioxidants, and essential omega-3 oil. Concentration and focus. Focus Factor. Nutrition for the brain. Available at these fine retailers.
Okay. So my story is this. I remember literally still living here in Tallahassee and apparently got a phone call from someone talking about this particular product. And I don't remember the details of those conversations, which I guess what I did know is that for the next 3 months, I was getting 90-day, these big bottles of this Focus Factor with the bill. Okay, and the bill was between I think the first shipment was $60, and then the next shipment that got shipped back to them was $90. And, you know, I had to call them and remind them, do not send me that stuff to the world of herbals on a personal level. But being in the memory disorder clinic at Tallahassee Memorial, I learned so much from the patients I was able to actually interview in their patient encounters. And one of the things I was really proud of is I would always emphasize, and we would send them little brown bags so they would bring their bottles of medication with them. But I always have to emphasize everything. Just clean your medication cabinet out. Now, sometimes I got bags as big as the bag you got at the registration desk full. I got cardboard boxes with all kinds of things in them. There'd be stuff stuck in their pocket, but they would never think of herbals and vitamins as medications most times. So I really had to do a lot of everything, because they figured if the doctor didn't write the prescription that everything else was safe, because it was natural, because you had commercials like this that were getting their attention and talking to them, or they read something on the internet. So I want to talk to you about the limitations of direct-to-consumer advertising and what it's doing and how it's impacting the impressions of consumers like yourself and even myself in terms of that. So we see those kinds of commercials, and next thing you know, all understand Alzheimer's disease is doing. We're in Florida, it's a very sensitive issue because we attract a lot of snowbirds from everywhere, not to mention that we just have an aging population here. So when you look at the cost, the healthcare costs, and what it means in terms of us needing to establish ways to either prevent and or treat this or give it some sort of attention, you know, it's quite very interesting. But I think this last point really ultimately the goal that both a patient and a caregiver and the family really comes to. Time, the patient wants to maintain independence. The caregivers probably are concerned about safety, right, and health care or health or welfare of the individual. But at the end of the day, none of us really want to have to put our loved one in a nursing home or an assisted living facility or anything. We want to live in dignity despite the impact of the disease. So with these kind of things, is they establish these multidisciplinary clinic processes that would allow for early evaluation and in some cases treatment and or individuals and our hopes of improving the quality of life for people. Now so for those of you that had not heard and cannot appreciate what the Bird Institute actually is, I thought I would just take a few moments and show you a little bit about what we're doing and where I'm at. So this is our big, pretty, shiny, is a sight to see both outside and inside. Literally probably close to 25 or more basic scientists who are determined to find the cure for Alzheimer's disease. We have a very impressive vivarium in the basement, genetically modified mice that look like in a human. And so they're able to do some very, very, very high-tech research in that regard. And so we're really, really, really proud of that. The Base Center, and we actually utilize the second to see if there's any medical issues. We can do imaging. We can also check for balance and falls. We can do driving testing. And it goes on and on in terms of some of the things that we're doing. The individuals here, this is our medical director. She's a geropsychiatrist, and this is our PET scan. And the PET scan is actually the link of yesterday and today about diagnostic opportunities for the disease. And so one of the things that we're really proud of is, one, we have this big, beautiful machine, and the fact that we, in terms of research, are able to incorporate what the imaging piece does to us. So before I go to that, I want to where they actually have the PET scan in this line and this line. Really had to take that wall out. That's by the building. So I really wanted you to appreciate that. So we're really proud of this big machine. And you might say, well, what's the big, the big who? But what it does actually is allow us to detect these biological markers, and I know Dr. Pomodoro will do a lot more justice than I will. But one of the biological markers is amyloid plaques, and the PET scan actually can detect it in the brain. That use the machine also for other disorders, not just for Alzheimer's disease. But for the most part, this really has set us on the map in terms of research, and as part of the reason why the Bird Institute is considered one of the premier to detect these amyloid plaques. And the significance of this is this puts us in the we can actually think about detecting it long before symptoms actually present themselves. So around people start usually having memory decline or Alzheimer's disease. What age? We've all heard this probably, but somewhere around 60s. Well, it's postulated that these amyloid plaques may start growing in the brain as much as 15 to 20 years before we see the symptoms. So imagine if you're our age, right, and you're able to detect these kinds of things, what that means in terms of preventing either the onset of the disease or just slowing it down just a little bit more, modifying life in some kind of way, and or utilizing medications and other things that would take us to a whole nother universe as we talk about impacting the outcome of the disease. So I just wanted to say that to you as an introduction to say this is where we're going, and unfortunately that back. So whereas we can't just yet take a blood test necessarily to see if you have Alzheimer's disease, we can actually look inside that brain and detect other items. We also utilize the cerebrospinal fluid and other things, but nobody really wants lumbar punctures and that kind of stuff. It's a little too invasive. Now, you do know this kind of imaging comes with a price tag, right? So no, not every one of us can't just run up and go get our brain scanned, but certainly there are research opportunities right now, and if you can so afford it, and you have at least $2,500 or $3,000, come on down to the Bird Institute. We'll gladly help you out. By 2020, we will have discovered the cure for Alzheimer's disease. Pretty ambitious, isn't it, considering it's 2016 now. So some of the things that go into this pledge that has been made at the Institute is that what we hope is that individuals, now this slide says around 60, 65 will, in the process of being worked up, naturally go get their brain scanned, but we probably are going to adjust that to 40, 50 even, and say we may do some scanning a little earlier, and then at least that kind of gives us a baseline in terms of where we're going. So some of these things for individuals that do show these amyloid deposits or other biological markers, we'll use that to determine next steps for treatment and other things of that. this pattern of prevention, delaying the onset of the disease, etc. But in the meantime, we've got to think about some other things that we have to do. So just wanted to give you one slide that does kind of put this in context as I talk about these amyloid plaques or amyloid deposits. So this particular slide here shows you what's happening at a cellular level in the brain. We have neurons, and normally this is kind of what they look like. Well, in the patient with Alzheimer's disease, what we end up with is basically the neurons seeming to have these tangles within the cell, and then outside the cell, we see these plaques. That's where the plaques build up. And so what we're seeing on the PET scan is actually evidence of these plaques building up. Now, the challenge is that these abnormal proteins may cause processes to take root in the brain, such as inflammation, and other things like setting off our immune system. And so we do get concerned about that, but that's creating opportunities for treatment also in that regard. So one of the things that we're having to do is think about this disease as one that we don't just have one approach. And right now we have a class of medications that really only addresses one of in that regard. So when we look at the different theories, the current medications, Aricept, Namenda, they're helping us, but based on our understanding that what is eventually happening in the brain is that the neurons, some of the important neurons that are degenerating are the ones that secrete a chemical called acetylcholine. And so this cholinergic process or mechanism or theory is the thought that we're getting the disease partially because we're having severe decline in acetylcholine or this memory chemical in that regard. But it doesn't allow us to explore what we need to do in these other cases. So as I bring up amyloid plaques and all tangles and those kind of things, that gets us into some of the other theories. So we do have quite a range of options, and our research is telling us we really need to focus on the amyloid hypothesis and the neurofibrillary tangle hypothesis in addition to some of these other mechanisms to totally treat the patient. Okay? And so having said that, a lot is going on in a nutshell. A lot is going on. So it's hard to think of all of this stuff happening at a cell, but this is just another picture of what would be happening. Acetylcholine would go from one neuron to another and facilitate the learning process. Our medications currently pretty much help save acetylcholine, but they're working on the understanding that you have healthy neurons that are secreting acetylcholine. So as the disease progresses and you have more brain death or more neuronal death, then that theory doesn't help us, which is why it appears like our loved ones seem to respond for a while and then they stop responding. And that's because the disease is still progressing. So what we're doing now is thinking of disease-modifying therapies that we may in fact start using 20, 40 years before we get symptoms based on our understanding of risk factors. And so these are classes of medications that some of our researchers are working on, medications that may in fact provide immune protection or assistance. Or prevent their growth altogether. They may also affect the growth of the tangles. And I will again default to my colleagues on how to better explain what we're thinking right now in regards to tangles versus plaques. But I will say that in the Bird Institute, our feeling right now is that the amyloid picture is probably what we may see a little early on. What we don't want to happen is to start seeing increases in those tangles, because at that point we start seeing the evidence of symptoms starting to occur. And so it's really an exciting time in terms of research in this area. And so when you hear these terms, don't get intimidated by it. Just know that what we're doing is switching from what we call a symptomatic approach to treating this disease disease to now a disease-modifying approach, where we're in this neighborhood of prevention versus just treating and responding to what we're seeing. Okay? So let's all take a deep breath and let that sink in. And now I want somebody to ask me some questions before I move a little further. Yes?
What about myasthenia
this isn't a
gravis and
microphone.
the acetylcholine problem? Okay. Does that affect memory?
So, yes, and her question was myasthenia gravis, and are there memory issues in those kind of disorders? Yes, we do in fact see memory decline in myasthenia gravis, Parkinson's disease, and other things like Huntington's, multiple sclerosis. You can very well see that because acetylcholine is associated not only with memory, but with movement of muscles and saliva production, you name it. So yes, we can actually see it. Will there be a role for some of these therapies there? Potentially. And as I talk about the herbals, you'll see kind of where I'm going there. So did that kind of help you a little bit? Okay, great. Any more questions? Yes, ma'am.
Could you give an example of immunotherapies?
So we kind of started, her question was to give an example of an immunotherapy. So we have some medications now that we currently use that we give by injection. This is probably more in the drug discovery mode for Alzheimer's disease. So some of the things that we are looking at are things that are already on the market to see if they kind of help. So we have from cancer drugs to what we call interleukins, and some of the interleukins are the drugs we use, say, in multiple sclerosis or in hepatitis C. Some of those examples would be Rebif or Avonex or Beta-Seron or Extavia. But again, the research is kind of early as it relates to Alzheimer's disease. But again, when we talk about those biologic kinds of medications, they're $3,000 and $4,000, a month or a year. So when we think about access to care issues, we have to be, very strategic to who gets those medications and stuff. And so that's another part of our challenge here. These secretase inhibitors, the selective, A-beta lowering agents, that's the amyloid plaque acting drugs, those kind of medications are going to be extremely expensive. And so that's where, that's one of the caveats to using those high-tech drugs. Yes, ma'am.
So as you'll become clearer about early testing, testing in your 40s, 50s, whatever, how will you know who needs to come in? People who have loved ones who have had dementia or Alzheimer's? Or is it like every black man at the age of 50 start getting colon screening? So everybody over 45
So there's a couple of approaches. The memory disorder clinic started out doing memory screens.
Could you please repeat the question?
Okay, I'm so sorry. She said, so who in essence would be appropriate for us to do this detection or this screening early on? So yes, family history would definitely help us. But then we have a long list of risk factors that we know about, some starting with gender. Now, we know women are smarter than men inherently. Let me just say that. No, but certainly there's just a lot of data showing that women do tend to acquire the disease also more, but we also live longer. So maybe that's why we have the disease more. So we factor in family. Obviously, age is a risk factor. As I mentioned in a few slides back, we have about 10% of people over age 60, 65 who end up with the disease. But once you get over 85, those numbers go up like to 40%. So age definitely is a risk factor. We do have certain ethnic groups that seem to be more at risk. For example, African Americans, Hispanics, and others. But part of that is wrapped around lifestyle. And with that, you see higher incidences of other comorbid problems like hypertension, diabetes. And so your incidence of stroke, heart attack, and all are going to be higher in any individual that has those medical problems as well. So we have to filter out all those kinds of risk factors. Education is another risk factor that we have to take into consideration. So again, if you would meet a certain threshold, I guess, with the risk factor profile, then that may be a prompt that we want to do it, kind of do some screening. Now, what we do with the memory disorder clinic clinics and at the Bird Institute do actually provide a actual baseline screening. Now, one other thing that's happening in research is there is genetic testing, and with that, we do know a little bit. We do know that there are certain populations that are more likely to have a polymorphism. ApoE is typically the common one you'll hear about, and it tells us that they're at a certain risk for a certain type of dementia, but that doesn't speak to all ethnic groups. And so there's research, some of which I'm involved, that looks at what is it that other groups are having. So eotaxin, cystatin C, and it goes on and on, are some of these genetic risk factors that you might see elevated in other ethnic groups. This may be a part of our workup at some point, for individuals who are suspected of it, not to mention the subjective complaint. So to add to that risk factor profile, individuals with traumatic brain injury may also be at risk for Alzheimer's disease and other memory decline disorders, although we tend to see it being very transient. It may actually resolute itself. If you have certain health things like thyroid disorder, B12 deficiency, and those kind of things are also some things we have to pay attention to. So we could talk all day about who should get this testing. Just kind of wanted to open that up to you. I'm going to take Mrs. Shirley's question, and then we're going to get back to the presentation and move on. Yes.
Would you talk about the effect of statins, the benefit, and specifics?
So primarily with the brain, what's going on is the brain is not only helping us remember and think and just move through time and place, et cetera, but it also, we have processes like cholesterol production that take place in the brain, and cholesterol actually facilitates memory and assists. We also have glucose metabolism that takes place in the brain. But we do know that in the diseased brain, these processes sometimes are modified. So the statins, it gets to be kind of controversial because we need this cholesterol to help us remember, but they actually impair the enzyme that makes cholesterol. And so in some cases, what we still end up seeing in some patients for a short period is confusion, and then in some cases we see them kind of clear. Won't be a primary impact just yet, but we are tying some of that to and starting to look at, is there an impact on beta amyloid production and those kinds of things. So again, all of this is interconnected, and this is why I say polypharmacy will be the name of the game with this disease because of these differing theories. Now, the bigger challenge is every patient is different. And so it won't be that everyone's going to respond to everything or can afford the side effects that kind of go along with using some of these therapies. Thank you for those questions. Excellent questions. So after saying all that, I just want to remind you, we've been studying Alzheimer's disease for a long time. And I know when I first got started in the late 90s, there were 26, 30 drugs being investigated. These are but a few that failed and ended up becoming herbal products or natural products sold in other countries and or directly advertised to you. And so we just need to know that the research becomes very, very important. And when you look at a pretty box like that, aren't you tempted to want to buy it? Don't you have faith that it's going to work? So we do see a lot of that. And I like to ask this question, or talk about this. Why is it that consumers are so willing to use something that is supposed to be natural or hormonal? What is the draw with the herbs? Well, part of it is because our prescription medications are really only slowing the disease down. They're not curing it. They're not replacing what we've lost. And we're still learning a lot. Sometimes people can't tolerate the GI distress they cause. Sometimes it makes them more belligerent. They are not cheap, but most of those therapies are between $150, $200, and with the newer product, about $300 a month. And that could be, kind of imposing. And then we're still learning when we should use which one first, how long we should use it, et cetera. But they have to take it forever, just like hypertension medication or diabetes medication. And so the other problem, the bigger problem, is that Alzheimer's disease is a progressing disorder that gets worse with time. And so because of that, it's really, we see a lot of individuals using herbals as last resort, or they want something. They want some relief, and so they're tempted to try to use this stuff. So in 1997, and Ms. Shipman's in the audience, she can relate how I used to do flip-flops over people coming in with ginkgo. And then we started seeing people coming in. We go out on memory screenings, and we see a lot of that. Then eventually, probably early 2000s, about stuff that I needed to know about. And we're not teaching this to this extent in pharmacy school, so we have some awareness, but not total awareness. So, Ms. Shipman, since I left, this is but a few of what I deal with when I tell a patient, please bring what you have in your medicine cabinet. So we're going to talk about a lot of these and really what's the beef behind it, okay? What's the evidence, really the science? And I think that becomes, and instead of boring you with a lot of studies, I just want to tell you there's a lot of products out there. One, this slide shows you a whole lot of other ones, and additional supplements. And sometimes when we use the terminology, we call a vitamin a herbal, and a herbal a vitamin, and a supplement and natural products and complementary alternative therapy. At the end of the day, if a doctor's not writing a prescription for it, it may be any and all of those things, okay? But we do have a lot of things out of respect for cultures that have used some of this stuff for years. I'm going to talk about turmeric or curry powder, and to say that we won't discount it. So as I help you answer the question, is this our future? I will say that there is a role, and there is some actually impressive information out about it. So the way I thought I would present it to you is I've used a standard text that I use in my alternative medicine course that actually does look at the scientific evidence to talk to us about the collection of studies out there. And so that when you look at these studies, what it does is filter out those not so good studies from the good ones, and then compares and contrasts it against what we know needing to be necessary in regards to managing that disorder. So it's simple grading. A means very good, and F means we don't really have a lot of science behind it. So as we walk through, I'm going to do a couple of the main key, most popular ones, because as I mentioned, there are probably 500 products out there that have either one or combinations of some of these herbals in them. And so I just want you to get the gist of where we're going so you can understand. So I thought I would start out with ginkgo. So what I want you to walk away with this slide, one challenge with the herbals is simply this. Herbals have multiple indications and very little science. The prescription products are allopathic products, those things the doctor is writing you a prescription for. Companies have spent zillions of dollars to prove they do one thing, and there's a lot of science behind it. So those are two differing things here. So when we look at ginkgo, ginkgo does everything, okay? Very impressive things. We can't always answer is the how, all right? And so when we look at the report card, pretty good report card, wouldn't you say? We'd be a little upset if our child came home with this many C's, but for the most part, we'd encourage them and say, try again next 9 weeks, right? But let's put this in context. So what I did, you have a lot of these slides. I have the name of the herbal, recommended dosing or common dosing, what they may be used for, and that grading, and then the how it works, and then the side effects. Now, this column is really important because what I want you to do, your homework as we're talking about this, is I want you to look for keywords. Beta amyloid, right? Acetylcholinesterase inhibition. So we got to go back to thinking about the core reason we have the disease. And I spent a little time talking to you about that intentionally. So as we answer the question about these herbals, you understand what you're seeing when you go home and you look at this handout and you're like, all of these multiple syllable words make no sense to me. But what I do want you to notice is that ginkgo actually is getting a grade in dementia. Now, dementia is our umbrella term for all these memory declining disorders, right? With Alzheimer's being our most common. But we do have vascular dementia. We have dementia associated with Parkinson's disease. We have Creutzfeldt-Jakob dementia. We have Lewy body dementia. We have frontal temporal lobe dementia. So when you see these terms, I don't want you to think everything dementia is Alzheimer's, but in most cases, about 60 to 70% of that is what we're referring to. So don't get fooled by that. But we do have some keywords here I think that helps. Prevention of beta amyloid aggregation. So that is part of why ginkgo has always been giving us hope. Now, one of the things that I know, if nobody else in the clinic, they could tell you, Dr. Hill is going to say, if ginkgo is used, the risk of bleeding and bruising is what I'm most concerned about. And the reason is because most of the patients that come in, they're older, they're at risk for strokes and heart attacks, they're also taking a baby aspirin, right? And so we can end up with bleeding in places we don't want it, particularly in the brain. So the reason I included the side effects is so that you as consumers can understand that these natural products aren't as benign as they may be advertised, despite the testimonials that you're seeing, despite these wonderful commercials. So in that regard, the other bigger problem, particularly like with the ginkgo, is we've got 5 different companies, 5 different strengths, and the consumer doesn't have a package insert that leaves with this, like the ones that leave those prescriptions that you all get that you don't read and throw in the garbage. You won't get that from these products, okay? So that's one of the other problems that we have is the consumer is not led to know what strength they should be getting and how they should be using it. And I promise you there's probably different directions on each of these products. So this is part of why, on one hand, I say there may be a role, but we're not quite sure which patient is appropriate for that. Go-to-cool is another example. Multiple indications, but supposedly may protect the neurons from this beta amyloid toxicity. It's got a lot of B complex vitamins. Very good. The B complex is really important because we know memory does occur sometimes from B vitamin related deficiencies. Works on GABA receptors. And in terms of the side effects, liver toxicity kind of worries me, right? And then additive adverse effects with other things that may in fact affect the liver or the brain. And so these are things that I then have the burden to actually try to educate consumers and then a lot of times discourage them about having faith in these kinds of products. Not to mention that we do have potential drug interactions that could occur. So I'm not saying go-to-cool is not good because when we didn't have these allopathic drugs, that's what people were doing. They were chewing the leaves of the go-to-cool tree and using it as a memory tonic in past cultures. But we're way beyond that now. And we wouldn't know a go-to-cool tree if I gave it to you. So we don't have to do that. Now the closest we get to an herbal version of our allopathic cognitive supporting agents is Hooper's A. It's a Chinese herbal moss that grows, and it works literally like our prescription drugs, reversibly inhibits acetylcholinesterase, and it works like Namenda. It antagonizes a receptor that we think is associated with cellular destruction in the brain. And it is used in myasthenia gravis, dementia, cognitive and function, so we do see this. And what we see are side effects that also are associated with our prescription drugs. So we do have quite a bit of things. Now let's look at its report card, B's and C's. And again, we're seeing Alzheimer's disease, and then we see cognitive disorders. We see a range of dosing, but this mechanism of action is very similar to what we're seeing with the Exelon product right now. Okay, so there is a role for it. Now, what you can appreciate here is that person that uses this product would have to take it at least 3 to 4 times a day. Okay, compared to what we now have on market, that's a little bit more than we want caregivers to have to deal with or a patient. And again, the side effects look very similar to what we're seeing with our prescription grade drugs. So for a patient who can't tolerate the allopathic drugs, then Hooper's A may be an option that we might want to take into consideration. So let's look and see another commercial real quick. See if any of you have seen this.
Do you remember the old days, guys, when this was all they had, right? The regular Prevagen. Look at the lineup now. Mark Underwood, the president of Quincy Bioscience, joins us on the website to talk a little bit. I want him to cover 2 things in the couple of minutes we have. Number 1, that this one product grew into so many. And number 2, that you no longer have to call in to get your Prevagen. You can get it this afternoon.
You can get Prevagen nearly anywhere. The Prevagen chewables, the Prevagen Extra Strength are available at pharmacies, health food stores across the country, whether it's chain pharmacies like Walgreens or CVS or Rite Aid, or if it's at your local corner pharmacy, Prevagen's there. We also have Prevagen Professional available through healthcare practitioners. We've got a product for dogs using the same technology to help a dog's memory get better, available at veterinary practices, and that's called Nutrix. Then finally, we have another delivery mechanism. It's in a shake. If you want to take your Prevagen, if you want to take this protein in a smoothie or in a shake or some format, NeuroShake's available for that as well.
The point I want to make here today, a little bit more intimately on our website, is this. This one product spawned several new products, even for dogs, even a shake, even one you can go to doctors, chiropractors, homeopathic doctors, or physicians, and pick up. It's a little bit stronger of a product. Now, the toll-free number you see right now is where you get information on which doctor, W-H-I-C-H, which doctor has this product, and which health food store, which pharmacy, et cetera, has it. They're all tens of thousands of them.
Yeah, we encourage the calls. That phone call, toll free, it's going to call our offices in Madison. It's going to talk to people in our customer service department, and they can tell you at the street corner where the closest bottle of Prevagen is to you. We can have it shipped out if that's your preference. We can answer any questions. Anything you want to know about Prevagen, please give us a call.
So you kept that entity of the business, and now you're expanding.
Absolutely.
So people can get Prevagen right away. I think it's just brilliant.
Oh, we love talking to people that like Prevagen. We love talking to people that are just curious about Prevagen and haven't tried it yet.
Yeah.
We love talking about it. So give us a call. Give us your most challenging question. Try to stump us. We love that.
Mark, thank you for coming in. I appreciate it.
Sure thing, Doug.
Do not go buy any Prevagen. No. Actually, though, the Prevagen report card I do want to share with you if the computer will allow me to.
Oh, I bet you never thought I'd start a note.
Stop. Okay. What I wanted to point out about the Prevagen, though, one of the things that it does that is unique is that it actually affects calcium, and calcium does facilitate some memory processes in that it allows the enhancement or conduction of acetylcholine across neurons to take place, et cetera. So this calcium-binding protein that we're getting from a jellyfish, certainly is the part of the reason why this product is unique. But the other thing is that the science actually implied that spatial memory and executive memory may actually improve compared to placebo, meaning people who got nothing. And so this is the kind of stuff outside of, and in addition to that commercial, where people are, getting tempted to use it. When we look at, though, the report card based on all the science, insufficient evidence just yet. So that's why I say, don't spend the $60 on this one. They say none reported, but we're still learning, so possibly restoring calcium balance basically in the brain. So this is kind of what we see. If we look at turmeric, how many of you eat curry chicken? I love curry chicken. Ever thought about curry as a medicinal agent or heard about it? Well, it does a lot of things as well. It's actually an Indian herb with antioxidant, anti-inflammatory, and lipophilic action. And what we do notice is some of these keywords, beta amyloid plaque formation, delayed degradation of neurons, metachelation, But in a nutshell, it implies that curry may actually be helpful, but the report card isn't super impressive for Alzheimer's disease. But we do see a lot of the what I call pharmacology that was speak to modifying the disease in a significant way. Now, what scares me the most, though, about curry is the side effects. Blood pressure dropping, pulse rate dropping, thyroid gland being affected, bleeding, and the kidneys being affected. That becomes the risk here. So when we eat curry chicken, we're not eating enough to probably make a difference, but we also don't know how the heat modifies the impact of the curry in any way. But what I will say is that we need to do more studies. And so that's why you'll hear that as a default from health professionals about using products like this. The other thing is I don't want you to get fooled by naming, because you hear turmeric and you think, oh. And then if you research a little bit more, you may be fortunate to notice that it's curry powder. So what you're buying out of Winn-Dixie and Publix is okay. Go ahead, continue making your curry chicken, but don't necessarily hang your hat on it in terms of Alzheimer's disease and treatment, but know also, more importantly, that there's some side effects that may come into this. I just want to show you her picture. I'm not going to show you this video, but Dr. Newport actually lives kind of close to the Tampa area. And I did have the link in your handout, and as some of you may have seen her on TV. But the background with her is she was a pediatrician whose husband had Alzheimer's disease, and she gave him some coconut oil. How many of you have heard of the coconut oil story? Okay, very impressive. We actually were able to evaluate him in the Institute. And so one of the things out of her story is that she basically was saying it made a difference. He was able to draw a clock, and in the actual interview, she shows how he was able to do things. And when we saw him, actually very impressive. But unfortunately, those effects only lasted about 6 months. But the good thing that came out of it is we actually have a study where we're using a commercial-based coconut oil product and evaluating and seeing if we can at least see if the issue was with dosing or if there's something else we need to be thinking about as we use coconut oil. So I don't want to discourage you all about all of these products, but I would say that one of the things that has always already evidenced itself in our study thus far is the impact on the cholesterol indices themselves, and so that poses a risk. We do want to see an increase in HDL, but not necessarily LDL in the GI disturbances. But what it does, I think, is what I really want you all to know, and what it actually does is help facilitate this issue with glucose metabolism in the brain and production. And so it does correct it. So, you know, in the world of diabetes, you hear us say we don't want them to develop ketone bodies. Well, coconut oil actually is providing ketone bodies or an energy source to the brain, and that's what's facilitating the memory process in that regard. And so we do see some key stuff, but ketone bodies is the main thing, and we think that that may actually prevent some of the damage from the beta amyloid accumulation. And so that's the plus part. Now, we don't have enough evidence just yet to give it a solid grade. We do know those with the ApoE4 gene variant may be the ones that we need to use it in. So these are some of the questions that the science will allow us to eventually answer. But just so in case you know. Now, I do want to talk about marijuana, because how in this time where marijuana is being looked at to cure everything, marijuana also is being investigated for brain research. We know seizures. If you've heard of Charlotte's Web, that was one of probably the first exposures the public had to a medical benefit outside of glaucoma. But one of the things is we actually do have a scientist in our institute who's studied marijuana in addition to the caffeine stuff. But he did it in mice, which is why I have our little friend up here. So we have a joke that we can't find spaces in the parking lot for the mice running up to the institute who want to participate in the research, because we get a lot of calls about people wanting to participate in the marijuana study. And I just want to say that right now it's still at animal stages. But what we have appreciated is that marijuana will actually, certain concentrations of THC may in fact sweep out beta amyloid deposits in the brain. But we haven't fine-tuned the dosing. The grading right now is about sea level, but it actually, you know, may in fact be beneficial. But the side effects are things that you have to be cognizant of. The formulation are those kind of things that you have to be thought of. So I do want you to remember right now, still at animal stages, not human stages. And then Procera is another example. I saw this here in Tallahassee too, where we've got these products that have multiple ingredients in them. Huperzine A I've talked about, but the vinpocetine is actually an antioxidant, and acetyl L-carnitine is an acetylcholine-like ingredient. So you'll see these kind of products on the market. But again, we got different grades ranging from B to D depending on the use. And that means when you have more than one ingredient, you have all of the side effects and all of the drug interactions that kind of go along with it. So that becomes a challenge in using those. And then I think my last one is caffeine, and I do want to revisit that because there has been a lot also on the news about caffeine being our link. But how much coffee can you drink, right? And so the same scientists did find that caffeine does facilitate neurotransmission of acetylcholine, and what we need to do there regarding memory may actually help prevent damage from beta amyloid. So there is something there, but this is what we saw. And in speaking and working with this researcher, he said approximately 15 cups a day. will be around what we may need to equate to what he was seeing in animal studies. And so I don't think any of us probably want to ingest that much coffee, but that's the reality of this. So some of my final comments about herbals is we still have to break through all of these barriers. We're still working on purity, some of the issues with adulteration. We still need to make the regulatory process, in other words, a little bit more sound. But there is a role I think that these products can play. And my other key word is yet. We don't have the studies using them with the allopathic drugs, using them in other dementias, using them as people progress, using them for prevention yet. And so until we get there, I would say let's use our allopathic drugs as first line. We also have another class that we're using quite a bit, Exona, resveratrol. That same researcher was involved. The marijuana caffeine guy was also involved with some of our resveratrol studies at the Institute. So doing very impressive things, but still we're learning. What these products do predominantly, again, is very similar to coconut oil in that they feed the brain alternate sources of energy to help with glucose metabolism and in turn help the brain function a little bit more efficiently. So we do have a lot of things. There's data out there about vitamin D. We think that it may actually facilitate getting that beta amyloid out of the brain or broken down. So all of these high terms, that's all that really means. So again, it opens up opportunities for things that we need to monitor as we're working the patient with Alzheimer's disease up. So we may be adding vitamin D to that list of things that we rule out in these kinds of patients. So where does it leave us? We're going to still probably use these products for right now. Wait on the science. I think we're within 5 to 10 years in getting some of these disease-modifying therapies available to us. We keep in mind that they're not curing anything, but they're focusing on that cholinergic mechanism I talked about earlier. Memantine is focusing on minimizing the destruction of the neuron, and we can use them in combination. We do have a variety of formulations that individuals can try, and this is for the caregivers so that you're not so burdened with their administration. You can later refer to these, but I do actually have a handout, and I may not have enough for everyone, but it has additional tips on medication management for those of you, and it speaks to the use of other medications. But in a nutshell, this slide summarizes some of the key things I want you to remember as we use what we have. So if you're taking the once-a-day products, there's a certain time they should be given. Breakfast with food is the key. If you're using the patch, know where to put it. Make sure you take it off every day. Those kinds of things. And if you have a question, I've been educating now going on 25, soon to be 24 years next month. Ask a pharmacist. And if they tell you if they went to FAMU or USF, they've heard me say all of this. So you ask them, what did Dr. Hill say about using the cognitive supporting agents? But that's what's in the handout as well as in your packet. And this stuff becomes very important. We do have the new product on the market. For the most part, the clinicians are making sure that the dosing conversion takes place so we don't end up with unnecessary side effects. It does cost roughly about $200 to $300 a month because you're getting both ingredients in there right now. But what they do have is a 30-day trial with no out-of-pocket expenses. So that'll get you started. So you can check into that. There's also a website for caregivers so you can get support. So it's like an online support group for individuals using the product. But they have other useful tools and different things, advice from other caregivers, etc. So with that, I wanted to kind of end on a note because I know just this week, many of you, did you hear about the claim that our Protonix and Nexium products can actually be linked to dementia? How many of you heard of that? Okay. Well, if you didn't, NBC had a story talking about those medications and how they may be linked to dementia. And right now, the research is suggesting that that class of drugs may, in fact, deplete B12. And the B12 deficiency, we do know, is tied back to memory deficits. So what it may end up meaning is that as clinicians, we'll start monitoring for B12 in patients taking those medications. We may also start monitoring for vitamin D. Levels as well in those patients. So my closing comments are simply this: we still don't have a cure, but we have a lot of impressive research. It's taking us down the path of disease-modifying therapies in addition to our symptomatic therapies. The herbals may have a role. They might have a role. They work very similar to some of our existing drugs, or they're going to help us with that disease modification. But right now, we're going to keep them as last resort till we get a little bit more science, okay? And if you have any additional questions, please don't hesitate to reach out to me. My office is just in Tampa. That's what I told them when I left. I'm still here in spirit and always still here for you. So I want to start with that, and I do apologize for almost going over time, but thank you so much for letting me come back. Thank you. Thank you. Good.